thank you for joining us today for our outpatient rehabilitative therapy, Avoid the Most Common Medicare Claim Errors. My name is Mary Stu Gardner, and I am a registered nurse on the Provider Outreach and Education team. And I am going to be your facilitator for today's event. And I'm also joined by other members of the Provider Outreach and Education department who are going to be helping me with the chat questions as well as any Q&A at the end of this event. So the objective for today, I want you to learn about the most common issues that have been identified in recent claims data and how to prevent or avoid any kind of payment errors or delays. We're going to achieve that today by gaining an understanding of our threshold requirements. We're going to talk about when and how to append that KX modifier. We're going to talk about some common rejection reasons, as well as documentation requirements and some billing tips. So let's start with the discussion of the KX modifier and how that impacts both medical review and payment of services. The KX modifier is actually a billing modifier, and it's appended to your Medicare Part B claims when a patient's outpatient therapy services exceed the annual financial threshold amount. By adding that KX modifier to your claim, you're explicitly attesting to the fact that you need to provide continued care to your patient and that that continued care is medically necessary and supported by your documentation in the patient's record. So there is an annual per beneficiary incurred expense amount. But remember, your attestation of medical necessity must be supported in your documentation. So let's talk about a little bit of the history of the KX modifier. The Bipartisan Budget Act of 2018, that permanently repealed those annual limits, or otherwise known as caps, on the Medicare outpatient therapies. That includes PT, OT, and SLP services. So this repeal was actually applied retroactively and took effect on January 1st, 2018. It was actually signed into law on February 9th of 2018, but again, retroactive. So Section 50202 repealed what used to be the old therapy payment caps exception process. So while the rigid hard limits were eliminated, the Act instituted several specific billing requirements and some operational rules to help safeguard against overbilling of therapy services. So this became the KX modifier therapy threshold, even though some people often still refer to it as the therapy cap. So by using the KX modifier in these cases, you are no longer making an exception request. You are now making a confirmation in your billing of continued medical necessity. So let's talk about these thresholds themselves. So the KX modifier, again, is a billing modifier, and it's appended to an outpatient therapy claim. And that allows you, the billing provider, again, to attest to the fact that you need to continue doing medically necessary services for your beneficiary. So each year, there's a new threshold amount. So the lower amount, that is considered the KX threshold amount. So that threshold amount increases every year based on the Medicare Economic Index. And so again, that's adjusted yearly. For 2026, that lower threshold amount, or the amount where you have to append the KX, That's $2,480 for PT and SLP services combined, or physical therapy and speech language pathology combined, and the same amount, $2,480 for OT, or occupational therapy services. Now there's an upper threshold, and that's a targeted medical review threshold. So this threshold, at the upper threshold of use, your claims then are subject to medical review, and that's to support continued medical necessity. It does not mean that there's going to be an automated medical review that will happen to each of your claims, but it does mean that you are subject to have your claim halted in the processing and tend to a medical review request status. So this upper threshold amount is $3,000, and that's a fixed rate until 2028. And then after 2028, that amount will no longer be locked in place. So starting in January of 2029, that $3,000 benchmark, it will be updated every year, just like the lower one, and that's going to be done to keep pace with healthcare inflation, which means this amount will also be indexed annually by the Medicare Economic Index. So when figuring out the amount in which you need to append the KX modifier, you would use the incurred expenses by your beneficiary. So this includes any applicable deductibles and coinsurance as well. So for further questions or guidance on that KX modifier, I did provide a link at the bottom of the slide in your slide deck that you can refer to that. So how do you know if you are a therapy billing provider that must abide by this reporting? The simple answer is, if you are an outpatient therapy provider, even if you are providing services as an outpatient of a facility, then you must report the KX modifier when billing for beneficiary services that reach that KX threshold amount. So private practice, outpatient of a hospital or outpatient of a SNF, home health when not under a home health plan of care, FORFs and ORFs, and even outpatient of a critical access hospital. So let's move on and talk about when and how to append that KX modifier. We've covered this in the amounts area, but when the beneficiary's incurred therapy expenses reach that lower threshold amount, you need to start reporting the KX modifier. Again, this is your attestation to Medicare that you know the beneficiary has hit that monetary threshold limit, but they continue to need medically necessary rehabilitative services. So this modifier is applicable even if you are providing maintenance therapy. You must still be attesting to the fact that the Benny continues to need medically necessary skilled therapy services. Even when you hit your upper threshold amount, you would continue to still append it. So once you get to the lower threshold amount and over is just your easy way to remember it. So where does it go? The modifier would go in the modifier spot on your billing. So it is directly on that procedure line or that CPT HCPCS code line that exceeds that annual therapy threshold. Then on each line item therapy lines thereafter. So it's also used in conjunction with the therapy discipline modifier as well. So modifiers go in box 24D on the outpatients, on this outpatient bill example that I have listed here. The order would be, first you would report your procedure code, and then your professional modifiers, and then your KX modifier. So, you know, there's an example up here for you as well. Where do you check the amount used? The fastest and easiest way to check the amount used is to check via our portal, or SNAP, Secure Access Portal. From here on out, I'm just going to refer to it as the portal. This information would be under your eligibility check information. The eligibility check allows providers to verify certain information about a Medicare beneficiary, certain information that Medicare has on file for the beneficiary. So this information helps providers bill Medicare correctly. And you can access the eligibility by clicking on the eligibility link under the patient heading. So that the heading would be patient. It would be under eligibility. And then after you click that, you would select your service location if it has not already been pre-populated, and enter the patient information. So there would be a screen in between this and this, and that's where if your information was not pre-populated about you as a provider, you would enter it then. And then it gives you the opportunity to enter the patient information. It's going to ask for the Medicare number, or the MBI, first name, or date of birth. It's going to ask last name. It's going to ask if there's a suffix like junior, senior, etc. And then it's going to ask for starting and ending dates of service. So this information will correspond with the start and end dates that you enter, the information that's going to populate out of that. So make sure your dates are correct. You can search up to 4 months in the future. If the info you entered is valid, the portal is going to display the beneficiary's basic details along with the link to the additional eligibility category. And that's where you're going to find the therapy tab. Even though it's a therapy threshold, to make this easier for you to find, it's just labeled as therapy tab. So this is going to provide the info about the per beneficiary threshold amounts for PT, OT, and SLP services. So that therapy tab is going to provide the following information. So the type of therapy, it's going to provide the deductible year and the amount that's applied towards that threshold. So it's going to be labeled as Part B Therapy Cap U. Let's now move on and talk about the most common reasons claims are being rejected or denied if they are reviewed. So this is a medical review denial that is appended to a claim when all necessary documentation needed to complete the review is not submitted. So it's called lack of or missing documentation. This generally happens when a component of your documentation is just simply not submitted with your documentation. Remember, when submitting documentation for review, we need the initial eval, regardless of the dates of service that are under review, any necessary reevaluation. We're going to cover this again in a little bit. We also need to see certified plan of care and any necessary recertification. We need progress notes to be included, and we also need daily notes. And if you issue any ABNs or advanced beneficiary notices, we would want to see those as well. So make sure, again, we're going to cover all the documentation in the presentation in a little bit here. The next one are the rejection codes, the 7V822, 823, 824, and even the 772. So these all have a similar definition. So I grouped them all together. And the basic thing is the outpatient rehab therapy limit was overapplied. So again, these codes append to your therapy claims when that therapy threshold was exceeded in that monetary amount and the KX was not appended to the claim. So this generally happens because the eligibility amount was not checked before the claim was submitted for payment. The denial means that the claims system rejected payment because the billed service pushed the patient's annual therapy spending over that designated limit. Your resolution to the rejection codes of the 7B823 or 22, 23, and 24 is to do a claims adjustment and add the KX modifier if the services were indeed medically necessary and provided in accordance with Medicare standards. If, however, the services were not medically necessary, like if your patient wanted to continue therapy, but as a therapist, you did not feel that they needed continued skilled care, then you would need to issue an ABN. And in that case, you should have appended the GA modifier and the occurrence span code 32. Next are general documentation errors. So this slide actually includes a list of various documentation errors that we see upon medical review. The denial code describes the error. So for example, the TP001 is for plan of care not established by the qualified clinician or practitioner. And this would generally happen when there is no signature, so we don't know who established the plan of care. The TP002 would mean no certification was received with the documentation that was provided. So medical review denial codes, those can be appealed. If you believe that the service was medically reasonable and necessary, and you have the additional documentation to support that medical necessity, and in this case, you would just then follow the appeals guidelines that are listed on the appeals section of our website. I had Jennifer also place a link to the full list of these service type denial reason codes from CMS's website into the chat. So in case you would like to click on those, you can see the full list of therapy reason codes and statements. This next slide is just a continuation of those error reason codes that we generally see. And I've listed these, you know, as they kind of come up in our reviews and, you know, what our big issues are in reviews. So that's why they might not be in number order, but you can find the definitions of those under that link that Jennifer put in the chat for you. Okay, so let's move on with documentation, because this is where a lot of our errors come from. And we're going to start by talking about the components that we need. We've already covered this once, but just to kind of quickly rehash them again. We need evaluation and plan of care, regardless of the dates of service. We need any necessary reevaluations that were done, and those are only billable reevaluations. We need your certification and necessary recertification. Progress notes, including your discharge notes, because that's part of the progress notes, and then your daily treatment notes, which need to include your minutes of service. So let's break down the evaluation and plan of care to start with. Some of these things that some of the things that we're going to look for in your documentation of your evaluation and plan of care, regardless of if it's one document or two, we don't care, how you do it. It can have one eval, one plan of care, or it can be combined. It's usually combined. So some of these things include the reasons for therapy. Number one, what's the diagnosis? What's the therapy diagnosis? We're going to look for, and we expect you to document any objective information, such as tests that you perform, scoring of those tests, functional performance, and the patient's participation, as well as baseline testing to support intervention. I'm going to say this multiple times during the course of this event, but when you are documenting, anytime you can provide objective and measurable information, it is only going to behoove you as a provider to document in that way. Anytime you can provide a length, a weight, a measurement, a percentage, it is going to go very far in showing the progress your patient is making from when we look from progress note to a progress note. So keep that in the back of your mind. Always document in objective and measurable terms when feasible. Evaluations should also include any pertinent medical or family history, as well as any cognitive issues that may affect the interventions and services that you need to provide. Next, your evaluation should identify why the skills of a therapist are required. So, and this isn't my skills are needed because this is conveyed to us by the services that you pick, the documentation that you are starting to formulate, such as the goals, how you expect to achieve the goals, what kind of tests you need to do, what kind of services need to be provided, etc. So always think, why does this patient and this patient needing this type of treatment or service, why do they need me, my license, my expertise to treat them? Basically, show us through the development of your evaluation and plan of care what skilled services, treatments, interventions, goals, what types of those things are needed, and how do you plan to achieve your goals? That's what we're looking for. Part of the plan of care includes amount, frequency, and duration. So how much therapy, how often, for what length of time? When it comes to goals, we need to see your long-term goals, but short-term goals can also be just as important and helpful to support medical necessity. So if you do both, that's great. Submit those if we request them for review. And finally, if there's any referrals from other physicians, we would want to see that you have included that as part of your overall evaluation and plan of the patient. Why were they referred to you? What did the other physician feel, was necessary for you to do for this patient? And then any patient demographic information that's pertinent for the patient. As we continue on under evaluation and plan of care, so other components include proof that the evaluation was established by the correct person. So the evaluation plan of care has to be done by either a physician, non-physician practitioner, or therapist. Generally, it's the therapist. So no one under you, no one under the therapist could develop, formulate, change anything to your overall evaluation and plan of care. That includes updating your goals. We need to see that the evaluation plan of care was established before starting treatment. So this doesn't mean you can't evaluate and treat on your first visit, but instead it means it must be in formal written form before the next treatment day. Because very much we know that as a therapist, you're looking at the patient, you're formulating your goals, your plan for the patient, and you may be treating them at the same time, and that is very much allowed. You need to periodically review your evaluation and plan of care, which is what you do in the progress report. So we're looking that you are constantly reevaluating the progress towards your goals, the validity of those goals, and changes that may be necessary to the overall plan or treatment goals. Remember, no changes can be made to that evaluation or plan of care by anyone less than the therapist. So physician, non-physician practitioner, or therapist. So any changes made by someone other than these people would be considered outside their scope of practice, therefore deeming your services not medically necessary, which means denial. Finally, the evaluation, and I think I already said this, has to include your diagnosis and your long-term goals and your amount, frequency, and duration. I think I said that on the last slide for you, though. Okay, reevaluation. Now, when it comes to reevaluations, which is a separate payable service under outpatient therapy, it's important to note that reevaluations are not routine recurring services. They're covered only if the documentation supports the need. So that includes a new significant clinical finding, or if there's a significant change in the patient's condition, which would require an updated evaluation and plan of care. We do expect that therapists are constantly reassessing their plan of care. That's what you're doing when you're doing your progress notes. You're reassessing your plan. And, but those are not separately payable. Think about it when something significant happens to your patient, and now the plan of care you have sitting in front of you is really not valid for your patient, and you need to reevaluate them and see what they are capable of doing now. When that happens, we want to pay you for that. But you can't say, oh, it's the end of the month, so I'm going to do a reevaluation and bill Medicare and expect payment. No, that's part of what you should be doing during your progress report periods, is assessing how we are. Are we staying on track? Do we need to modify things, etc.? Certification and recertification. So your cert is your physician's approval of the plan of care, which has to be signed and dated. It's required for each interval of treatment. So certifications must relate to the treatment during that interval bill. When it comes to your initial certification, it's due as soon as possible or within 30 days of the start of treatment. They are good for the duration of the plan of care. So if you write your plan of care 3 times a week for 4 weeks, your certification period is at the end of that 4 weeks. It is also can be good for 90 calendar days if you have a patient that you know is going to need at least 90 calendar days of treatment, or when there's a significant change that warrants a significant change to the plan of care. So if you have to do a reevaluation, again, that's billable, then you also have to do a recertification. While we're discussing certification, I also want to say that an order for therapy services from your physician is not necessary. And that's since direct access exists. So an order is not required under Medicare. However, starting in January 2024, CMS did change the fact that if a therapist receives an order to evaluate and treat for therapy services, that this can then serve as your initial certification for therapy services. However, if you do not receive an order, as a patient came in, and direct access applied, then you must still obtain a certification from the patient's physician. Basically, we want to know that your patient is under the care of a physician. So either you get certification of your plan of care if you don't get an order, or if you do get an order to evaluate and treat, you no longer have to go chasing that physician for your initial certification. All right, move on to recertification. So when it comes to a recertification, they're due at the end of the episode of care. Like I said, if you did 3 times a week for 4 weeks, that's when they're due. 90 calendar days or a significant change, which would warrant a reevaluation. All right, now progress reports. And I know we had some pre-submitted questions on this. So progress notes are used by us as a contractor to help us determine the necessity of services. They are a way for us to look from one note to the next and see the objective and measurable improvements or skilled interventions that helped you achieve your goals or helped you maintain if you're in a maintenance program. So progress reports cannot be written by anyone other than the clinician. Think of a progress report as an extension of your evaluation. So the therapist, a physician, non-physician practitioner. If anyone other than the clinician writes a progress report, it will not meet Medicare standards, and therefore services will be denied as they were not rendered by the appropriate person. So just as, again, the evaluation of the plan must be completed and updated by the therapist or physician, so must the progress report. So nobody less than the therapist can make any changes to goals, progress towards goals, updates to the plan, etc. So any reports that are written by or even appear to be written by the assistant would be considered outside their scope of practice and not in accordance with Medicare standards. Therefore, it's going to cause a denial of your service. Now, your assistant can write information and provide it to you as the therapist on how the patient did with them in your absence. But I would be very cautious in calling it any kind of progress report or progress note. So it doesn't look like it could be construed as they were the ones that formulated the progress note. So we very much want them to give you information if they have information about how the patient did on the days that they helped with therapy services. But again, make sure when it comes to your formal progress note that that is written and completed by the actual therapist. And I would also caution you strongly of having any kind of progress note that looks like the PTA or OTA is the first signature on it and a therapist is writing a co-signature or co-signing it. Because that then looks like the PTA or OTA formulated the note and the clinician just co-signed off on it. So be very cautious with that. Let's see. I think I have beat progress reports down enough. Let's move on and talk about the daily treatment notes or treatment grid. That's the last component of documentation. So this is a record of all the skilled day-to-day treatments and interventions that the patient receives. So daily notes are used to justify your billing. So the documentation and the billing must match. It is required that every treatment day there is a treatment note of some way, shape, or form. That, again, can be done in the form of grids. That's just CPT code, the amount of minutes, who rendered the service, etc. That's usually how the grid comes out, and the amount of minutes. But it doesn't lend way to giving information about any subjective information that that patient told you, quantifying that into objective and measurable information, etc. So better ways from a grid, or have something that lets you complete a grid as well as provide objective and measurable information. Minutes must be reported. We need to compare those to the units of service that you build and make sure that it matches. So whatever you report on your bill, it's got to match in your documentation. And that's why you have to report actual minutes of service for each modality. So finally, your daily notes must contain some sort of signature and credential. If you're using grids only, then we must have some sort of signature log that shows who initials belong to and what their credentials are. All right. Now I want to round out this section with talking about better documentation, how that can aid in decreased denials. Remember, we will pay for services when the documentation plus the claim form equals the provision of medically necessary covered services that follow Medicare guidelines. So make sure your documentation supports your bill and vice versa. Make sure you are doing, if you're doing any handwritten documentation and you're scanning it into electronic medical record, make sure it's legible. Make sure your documentation is complete and it's relevant and it's correct. Make sure you're defending the codes that you choose. So know the difference between your codes and make sure that you're actually providing services that match that code description that you are reporting. And then finally, anytime you can, again, document in objective and measurable terms, you need to do that. All right. So a few documentation and billing tips to round out our day. Support medical necessity. This goes back to supporting the skilled service you're providing. When you think about skilled care, think about why that service needs you, your license, your expertise. What are you trying to achieve? How does this relate to your patient goals? What considerations are you making to any medical conditions that the patient may have? Standalone. Each of your bills must be able to stand alone when it comes to medical review. That means the record or documentation for that date of service is supported in your bill. Remember, if we do request a specific date for review or even a date range, you also need to submit the initial evaluation, as well as all documentations within that date range that we requested. I highly suggest you also submit the last progress note to the dates under review. Detailed skilled intervention. Avoid vague language, like we talked about earlier. Anytime you can use objective and measurable phrases whenever possible. It's still important to gather any subjective information from your patient or your beneficiary, but quantify it with that objective and measurable terminology. So if your patient reports they're feeling better today, ask them the leading questions. Oh, that's great, Betty. Last session, you reported your pain was 6 out of 10. What would you rate your pain today? Oh, it's a 4 out of 10. That's great. Now you have objective and measurable information that helps you support improvement in your patient's pain quality. You'd also want to include any pain descriptions, locations, etc. with this. Treatment time. When it comes to outpatient therapy, this is of utmost importance that you are capturing treatment in minutes, as most of your codes are time codes. You should be reporting in your daily documentation your total treatment time, which is the sum of all timed and untimed codes, as well as your time codes and the corresponding minutes for those. It is best to document the modality and how much time was spent in that modality. We briefly talked about this earlier, but it's important that you know your code descriptors and what modalities belong to what codes. Mostly the biggest offenders are the difference between therapeutic exercise, so the 97110, and therapeutic activities. And there are tons of even just Google searches to that, are going to help you in deciding what modalities fall under what CPT codes. I encourage you to master the 8-minute rule. Remember, when it comes to taking your time codes and reporting those on your bill as units, you must take into consideration all time spent for all of your time codes. So if you provide, in this example, 8 minutes of 97110, 8 minutes of 97530, and 8 minutes of 97116. In this example, you have a total of 24 minutes. You do not get to report 3 units. You do not get to report 1 unit of each of those codes. You can only report 2 total units because you only provided 24 minutes of skilled intervention. So which ones do you report? You report the 2 that pay the highest. That's the easy way to think about it. Or the 2 you spent the most time in, if it wasn't, 8, 8, and 8. I gave an example where they were all equal, but you would report the ones that you spent the most time in then, if that's the case. Accurate coding choice. Remember to choose the most specific and appropriate ICD-10 codes, as well as the most specific CPT and HCPCS codes. I'm not going to beat this dead horse anymore, as we've talked a lot about accurate coding choices. So we'll just kind of move on from there. Appropriate modifiers. Ensure that you're reporting accurate discipline modifiers. So the GP for PT, GO for OT, and GN for SLP, as well as any therapy assistant modifiers for those services that are rendered in full or part by the PTA or OTA. The SLPs don't get a therapy assistant, unfortunately, so that only applies to the PTA and OT headlines. There are some fact sheets on the CQ, which is the PTA modifier, and the CO, which is the OTA modifier, listed in the resource section of this presentation. Finally, as we discuss in great length with the KX modifier, remember, like we said back on slide 10, the order of reporting would be procedure code, professional modifier, and then your KX modifier. Know what's billable and what's unskilled. So our next tip is to know what's billable versus, again, what's unskilled and not billable to Medicare. Medicare pays for direct face-to-face services and skilled therapy interventions, evaluations, and complex reassessment. The key here is skill. Show us your value as a therapist. Think about, why does this service need me, my licensure, my skill, my bazillion years in school to become the expertise on your service? And again, that is reflected in your evaluation and then your progress note. Things that are not billable, rest periods. Do not include rest periods in your treatment time. What you shouldn't document is time into your treatment area and time out, because that doesn't allow for any rest breaks. You should document total treatment time. So again, your face-to-face time with your therapist and therapy assistant. Any prep or setup or unskilled supervision, that's not billable either. Finally, never ever round up service time to meet a billing threshold. And then our last tip we have to discuss is treatment notes and minutes. And we've discussed this really a few times already, but I just want to remind everyone that your daily treatment notes need to contain those exact minutes of skilled services that are rendered, because your documentation has to match the units reported. So upon review, if they don't, we could either flat out deny the line that didn't meet. We could maybe adjust the bill to match what we found in the documentation. And we could also flat out deny the whole treatment day if the documentation and the billing just do not match overall. So that's going to take us to the end of the formal presentation, but I'm going to pop up a few slides before we get to the question and answers. So again, this is resources. I've alluded to some of them. Go out and take a look. This right here, the Medicare Benefit Policy Manual, Chapter 15, Section 220 to 230, that is your Bible, regardless of where you provide services, because that forms the foundation of Medicare coverage criteria for all therapy services. So you should know this section inside and out. You can read the notes section of this slide for some additional information, but we did want to make you aware that as of June 1st, paper delivery is going to stop on appeals or redetermination requests that were submitted via the portal. So all providers that have active portal accounts who submit appeals through the portal, you're going to receive your review decision letters in the portal as well. But again, read the notes section for some additional information on that. Just a reminder on overpayments, the preferred way to handle these, again, is through the portal, and the instructions on how to do overpayment claim adjustments can be found in the link provided on this slide. If you have to do an overpayment via paper, use the second and third links on this slide to access the form, as well as information about how to submit via paper. And then this last slide is info on the National AV/NAC Ambulance Coalition meeting in September. So this is more applicable to any of you that are outpatient therapy providers that provide services out of a facility that may also have ambulance services. You can read the info in the chat for that if you want as well. So at this time, I am going to go over to the chat and see if I see any questions that have come into the chat. And I see one here: if a member hits their KX threshold mid-month, should we append the KX to all charges beginning at the first of the month? So the answer to this would be yes. If you are nearing in that month, go ahead and append it to all services, and you're dropping just one bill for the month, go ahead and append that to all lines that you are billing for that month of service. So let's go back. Regarding the daily treatment grids, are those actually a requirement? The therapist documents their time and treatments on a visit note and the CPT codes are listed on the claim. So no, a grid is not required. We just need to have some sort of daily notes with the actual minutes and the treatment that was provided that would match up with the bill, you know, with what you submitted on your Medicare bill. So we need to see what treatment modalities and how many minutes of service those were provided. And I'm going to ask, because our WebEx platform changed just a little bit, and I'm going to ask Jennifer at this time if there were any other messages, any other chats that came through that I did not see.
That is the only 2 questions that I saw in the chat.
Perfect. Thank you so much, Jennifer. Now, I do want to say we did receive some other pre-submitted questions, and some of those were answered as we went along in this event today, and others are a little bit more specific to specific billing circumstances. So I am going to email out the answers to all those questions to everyone. Oh, and then we have a question that came in. Can you clarify if Medicare accepts direct access patients? Absolutely, Medicare does allow for direct access, and that's why an order for therapy is not required, but certification is. So we do still, under Medicare requirements, want to see that the patient is under the care of a physician, and that is done via certification. Now, again, as we go back, remember that if you do receive an order and it's evaluate and treat, that can serve as your first certification. It can't serve as recertification, but it can serve as your first certification. It's a good question, Michelle. And okay, there's another, okay, whoops. And of course, the new platform doesn't make it easy to see all my questions in an easy manner. Oh, no, I got
ask
it.
you the questions? Okay.
I got it. It's great. Thank you, though. If you certify a patient for 90 days and then you need a recert, can you recert for 90 days? Notes are required treatment times. Do you need to include a time in and time out? Okay, so 2 separate questions here. So can a recert be 90 days as well? The answer to that is yes. You can recertify your patient for another 90 days if you have a patient that you know is going to need that length of service. So your therapists are the expertise in that, and they have a good idea, even though they don't have a magic ball, of the amount of time certain illnesses, injuries, et cetera, need therapy services. So sometimes it's a best guess. But if you know going in that this is a person that's going to need 90 days, and at the end of that 90 days, probably another 90 days, yes, you can recertify for another 90 days. And then notes require treatment times. Do you need to include a time in or a time in/time out? You can do it in a variety of ways. You can do a total treatment time, or you can put minutes associated with each modality or CPT code that you are providing for that day. Time in and time out of the treatment center does not lend its way to rest periods, other things potentially happening with your patients, etc. So I encourage you to not just say time in and time out of treatment for the day, because it needs to equate to actual skilled interventions being provided. Let me look. And we got both of those. And, oh, is there a guideline for progress notes around calendar days that we must submit, or is it just the 10 treatment visits? So yes, the guideline for progress reports is on or before every 10th treatment visit. So it's not surrounding calendar days, it's surrounding treatment visits. So if you're only seeing the patients once a week, you're going to have, 10 weeks before your progress report is due. And Jennifer, are you seeing any that I have missed?
I'm not sure if you got this last one from Rochelle. She asked, does the plan of care need to be signed prior to treating after the direct access eval, or do we then get 30 days to get that signed since there is not an order?
Okay, good question. Sorry, Rochelle, I did not see that. Again, they updated this platform, so it's a little tricky to figure out. So in the event that you're utilizing direct access and you don't have a physician order, you do need to obtain that certification within 30 calendar days. So you need to, unfortunately chase that physician down and get a signature within that first 30 calendar days. And they do need to, certify your overall plan of care. And then you are very welcome. All right. I think that is the last question. In the event, or in the interest of time, I'm going to move on, but I will take another quick peek before we conclude, and if there are any other questions. So we value your opinion. We want to hear from you on how we did on this event. And so we do ask that you take the survey, and it only takes a few minutes to complete. And Jennifer's going to place that into the chat section as well. And I do encourage you to take the whole survey. About midway through, it's going to ask if you want to move on. And I encourage you to say yes, because that's when it gives you the opportunity to say, what else do I need from WPS? What other kinds of education do I think would be helpful? So, I know we have survey fatigue, but please, if you have the time to do so, please take the survey. And I see there is one more question. What are the requirements if the physician has not signed the plan of care with multiple attempts to obtain? So if you didn't get an order to evaluate and treat, and you have to get the initial certification, and you've made multiple attempts, first of all, make sure you are documenting all those attempts and how you made them, whether you're sending it via email, carrier pigeon, USPS, certified mail, etc. If you get to the end of that plan of care or that 30 days, you may want to see if the patient has other physicians that might certify the plan of care. You may want to let the patient know that they could potentially be liable going forward because you do not have care that is under, or you wouldn't be providing care that's under the care of a physician. Sometimes I even say stick the patients on the physician, unfortunately. If they make a phone call and say, hey, this needs to come through so I don't have to pay, sometimes it's them making a phone call. So, that's been a long-standing issue, Sydney, but do everything you can, and that might include, unfortunately, having to limit your care to the patient or switching, trying to get a hold of one of their other physicians that might be able to certify. Maybe you're trying to chase the family practitioner, and maybe you need to go right to the orthopedic doctor or vice versa or something like that. Okay, so on behalf of myself and Jennifer and all of WPS, I want to thank you for your time and your participation in today's event. If you have any additional questions, There is an email address, and it's also noted in the speaker or in the notes section of the slide deck. And you can always email those questions to me, and any pre-submitted questions that weren't submitted, again, I will send those out in a form of an email. So again, on behalf of all of us, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.